Welcome back to West Texas View.
Welcome back. We're going to continue now talking with Dr. Joy Anderson about some of the women's healthcare issues that need to come to the forefront, some changes in policies that are a little bit different than what we're used to. And we were talking about the changes in pap smears before the break, and now we're going to talk a little bit more about some of the changes with mammograms and what is expected or what is recommended now in the way of mammograms. So kind of walk us through that and let us know.
It's still a controversial subject because there are physician groups that disagree on this. So I'll tell you what the American College of OBGYN says, which is start mammograms at 40. We stopped doing the baseline at 35, but start them at 40 and every year after that, and continue them. You know, we're screening for a type of cancer that we can treat and that we can find and is very treatable. So that's the whole goal with it. And as we were talking about before, you know, hereditary breast cancer is much harder to treat, and that's the kind that happens in women in their 30s. And I'll be honest with you, mammograms are not the best for breast cancer in your 20s and 30s. And there's some debate about how to check for breast cancers in those women. We're probably better off honestly kind of doing what Angelina Jolie did in those hereditary situations. And I hate to say that, but mammograms don't pick up hereditary breast cancers as well because they happen in younger patients, women that are young and have dense breasts,
right,
and have dense breasts too.
Yeah.
And so, you know, you do a mammogram on someone that's 25 and breastfeeding their kid, you're not going to see anything in that mammogram. You're really not. And so there's harm in getting testing when you're too young too, because what happens with a mammogram read, it doesn't come back and say your mammogram's normal. It comes back and says there are areas that are dense, watch them. And so now you've got a 25-year-old that's going to be getting mammograms every year because the radiologist, bless their hearts, appropriately so, is not willing to say it's normal.
Right.
And I agree. I mean, I wouldn't
Right.
either if I were in their shoes reading it and not knowing the patient. So there is harm to getting screening every year. And likewise with pap smears, if you screen every year on that and you've never had a bad change before, we're going to pick up some slightly abnormals. It's very much like checking your cholesterol every day. You're going to have a high. Show me something that's high enough to treat. Otherwise, we're not going to bother with it.
Right. So where does self-breast exams come in?
I'm glad you brought that up. We actually don't recommend them doing them anymore.
That is new.
Yes, I know. It depends again on who you talk to. We recommend breast awareness, and I don't like that term because what the heck does that mean? You know your lumps and bumps, and breasts are lumpy and bumpy. And we were talking at the break about, the first self-breast exam I did before I was a doctor, I was convinced I had 2 big breast cancers on my chest. You know, I can laugh about that now, but at the time I was scared half to death. And almost every breast cancer I've seen, let me correct that, every breast cancer I've seen that a woman's picked up herself, it's been doing something silly. Taking a shower, washing under her armpits, her husband found it during intercourse, things like that, or putting a bra on. I mean, I've had patients pick it up doing something really silly, and I've never had a woman come in with a self-breast exam that she picked up and said, oh, this is a cancer. What I have had is women coming in and saying, I feel a lump, I'm scared to death. And what a lot of people don't know is that any doctor is going to say, if you're scared, biopsy it. You can't diagnose cancer by feeling it. You diagnose it by getting a piece of tissue and looking under the microscope. If you're really scared, we're taking a piece of tissue out. And so there's problem with doing self-breast exam. You're more likely to find something that's not a cancer, something that's benign, and then get down a treatment pathway that you really don't want to go down,
Right.
especially when the likelihood of it being a cancer at 25 is pretty unusual.
Right.
And I'll be honest with you, if it's a cancer at 25, it's much harder to treat too. So early detection is debatable in that sort of situation. How much do we help these patients by detecting it early? It's hard to figure that out.
Right. So you said last week that so no more breast exams, self-breast exams. Mammograms have changed a little bit, but now as women get older, do they continue the mammograms every year, or is there a point where they back off?
We recommend continuing them every year, and that's ACOG guidelines, gynecology guidelines. There might be other guidelines with, the U.S. Preventive Services Task Force tends to be much more laid back about guidelines than we are. So it kind of depends on who you talk to, and it also depends on looking at a person and saying what your cause of death is going to be. I laughed about 82, but really the women in my family don't usually live past 80. And so you have to look at the fact that we all die of heart disease, we all die of obesity, we all die of diabetes. That's my chance of dying, not breast cancer, probably
Right.
not ovarian cancer and things like that. It's a lot like telling someone don't get in your car because you could get in a car wreck. Well, you take that risk every day because you feel like you need to go to work. And so it's more important. And so you look at the patient as an overall person and you say, here's what's important in your life. Let's get your cholesterol down. Let's talk to you about exercising. Let's do what's going to help you the most.
Right.
And it's hard because when you put out a guideline, it's not about a patient. It's about controversy in politics. And so there's so much there. You know, I'm sure the radiologists are going to say do more mammograms, and I'm sure the internal medicine people are going to say that, when we're kind of thinking we're trying to do what's right for the patient, and that's hard because you get a committee of doctors and there's going to be disagreement. Smart people disagree.
That's right. That's right. Well, so with the older women specifically, you know, you stop the pap smears, you're continuing with mammograms if they feel like it's necessary. At that point, do you see more environmental issues developing because they've had the diets, they've had the smoking for longer periods of time than some of the younger women?
Yes, and your cells have been around, and so they have time to mutate. I mean, it's the same thing as birth defects. You know, there's things that happen in the cell level, and there's not much you can do about that. So there are just, somebody's going to get a cancer if they live long enough and something else doesn't take them first.
Okay. Well, that's good to know. Well, so are there any other, in addition to the pap smears and the mammogram guidelines, has there been anything else that has changed recently with regard to that maybe women haven't been aware of?
There is an exciting new test called the cell-free fetal DNA test that is a way to screen for, it's kind of confusing, but it's a way to screen for trisomy 21 and other conditions. Usually it's more geared towards screening for Down syndrome. We actually check in the mother's blood for parts of fetal DNA. The downside to it is it's an incredibly expensive test, and I think a lot of times it's 99%, it's a very good test, but it's $500 for most patients. Insurances don't cover it unless you have a risk factor for it, like advanced maternal age or something like that. But I think a lot of times people kind of want the best test when, for example, if you wouldn't do anything different with your pregnancy, if you wouldn't change anything about having a trisomy 21 baby, then why get the test? And so a lot of times, again, it's looking at the whole person when you're talking about testing and patients. And so somebody can be 19 years old and come to me and say, I want the cell-free fetal DNA, I would do something different. And I said, great, we'll do it. And likewise, I've had a 47-year-old who was pregnant, who chance of Down syndrome was incredibly high, and she said, you know what, I'd love that baby and never do anything different. Great, don't do it.
Right.
And so it really comes down to talking to your patients.
I agree, and that is back to the relationship between the doctor and the
Absolutely.
patient, so I think that's very important. We're going to take another quick break, and we'll be back in just a few minutes to wrap up our time with Dr. Joy Anderson and visit a little bit more about some women's health care issues. Join us back in a few minutes.
Stay tuned. West Texas View will be right back.